Hello, everyone. Thank you so much for joining us this week for our weekly Wednesday webinar. We are just going to give it a moment, like always, to let the room fill up before we go ahead and get started. I hope you guys are having a great Wednesday. Welcome, welcome. Thank you for joining us this week. All right. I'm going to give it just one more moment before we get started. All righty. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on genetic counseling for ultra-rare bleeding disorders. My name is Alsa Murtha, and I am the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. And if you're joining us from one of our streaming platforms, you can go ahead and throw your question in the chat or the comments. We'll make sure that we get them answered for you today. We have NHF staff members monitoring these questions, which we're going to pose to our speaker at the end of the presentation. This webinar is being recorded and will be available to the community beginning on Friday, October 14th. I'm joined today by Tahnee Causey. Thank you for taking the time to join us. I'm going to go ahead and turn it over to you to get us started.
Thank you so much, Alison. I am delighted to be here. Thank you to NHF for this opportunity to speak with the community. I wish I could see everyone, but I think we're all used to virtual nowadays. So we're all experts at this. So thank you again for being here when we talk about ultra-rare bleeding disorders. I want to let everyone know, disclosure-wise, I am an employee of the Commonwealth of Virginia through Virginia Commonwealth University and VCU Health, where I am a lead genetic counselor and work at the Central Virginia Center for Bleeding Disorders, our local hemophilia treatment center. And I have no financial disclosures to report. So our mission, as you guys know, if you are regular visitors to the Wednesday webinars, we're dedicated to finding cures for heritable bleeding disorders and addressing and preventing complications of these disorders through research, education, and advocacy, enabling people and families to thrive. So what are we going to accomplish today? Well, we've got a lot to talk about today. We're going to really focus on what is the role of the genetic counselor as part of your bleeding disorders care team. Talk about family history and inheritance. This is all what we think about in terms of genetics. Give a little bit of a dive into possible options for genetic testing, and then give you some resources that you can find a genetic counselor near you to actually meet with you individually. So we're going to get into some fun facts about genetics. And this is going to be a little poll that you're able to access through Zoom. So, Alson, I'm going to have you rely on launch this as well. So our first question is, true or false? Humans have 20,000 genes. All right. Our next question, true or false? If we stretched out all the DNA in our body, it would reach the sun and back 600 times. True or false? And our last question is, true or false? The water flea is the animal with the largest number of genes. We'll give everyone just a second, and then we'll go over these answers. And this is just to give you kind of an appreciation of the wonders about genetics and how interesting, so many interesting facts that you can learn every day. I learn something new every day that I'm doing my job. So true or false, humans have 20,000 genes? That is true. We do have about 20,000 genes. If we stretch out all the DNA in our body, it would reach the sun and back 600 times. That's true. Think about that. That's an amazing distance. Think about all that in our cells. And then our final true or false question, the water flea is the animal with the largest number of genes. And yes, that is true. Who would have thought that an animal that is so much smaller than humans, than apes, and so forth, would have the largest number of genes? So just to give you a little bit of fun information about genetics, before we start to focus more on human genetics. So what is a genetic counselor? I'm hoping that some of you who are listening have actually interacted with a genetic counselor in some way, shape, or form, and that you could answer this question easily, but not everyone necessarily has had access to a counselor. So these are individuals who have a specialized Master of Science degree in genetic counseling, and that gives us extensive training and experience in genetics and in counseling techniques, because what we're doing is providing education to families about how conditions are inherited, what the risk may be to other family members, what testing options can give us information, and what those results mean for families in terms of treatment and management. But that also means adapting to the diagnosis and providing resources. If some of you think about when you were given your bleeding disorder diagnosis, it took maybe some adaptation and to figure out, okay, where do I go from here? And how can I get help, and where can I go for questions? Fundamentally, we always believe in promoting informed, autonomous choices. So every human being should be able to decide what's right for them, what's not right for them, when they want to do testing, when they don't want to do testing. So a genetic counselor is going to just simply give you balanced information and help you decide what's the right choice for you and your family at that point in time. So in a bleeding disorders clinic, what we're doing is we're working alongside the other staff. That includes hematologists, nurses, social workers, sometimes physical therapists. It could be education or nutrition as well. And we're going to take a family history, and we're really focusing more on the bleeding disorder that may be in the family. So even though we all know that there's lots of different things that may occur in our family, for bleeding disorders clinic, we're going to focus in on specifically what we're managing and evaluating for that particular clinic. So what we're really doing is complementing and enhancing the discussions that you're having with the other clinic providers. So we're working with hematologists to give them some information and suggest testing options. They're giving us information on what they found, and we're giving information right back so that we're providing you a seamless experience. Now, a lot of you who may be involved in genealogy have probably seen something like this, and we call it the pedigree, which is the family history. Now, I will tell you, I don't draw all these nice little drawings. That would be beyond my stick figure artistic ability, but it very much points out to how much we rely on getting some additional family history to help us get a clear understanding of the bleeding disorder affecting yourself or maybe other family members. But how does a family history really help? Well, bleeding disorders can affect people a little bit differently. So for example, if you have a parent who has your bleeding disorder or a sibling, then they may not have the exact same symptoms as you. So we're looking to get a detailed picture of the entire bleeding profile that may be in the family. A family history also tells us who's affected, whether it's males and females, or males selectively more seriously affected, or is there just one member in multiple generations who's affected? And that all gives us information about trying to tell how a condition may be inherited. So I'm going to give you just some examples of how something like this might unfold. So right here, we are seeing a patient, and her name is Margaret, and we're seeing her because she has a history of heavy menstrual cycles on a monthly basis. And Margaret tells us that she has 2 children. Her daughter, Kendall, and we know Kendall is a female and Margaret's a female because they're circles. And we know that her son, DJ, is a male because we've written that and denoted that as a square. So what we see is that Kendall actually had some bleeding after she had her tonsils out. But DJ so far doesn't have any history of bleeding. But if we look at Margaret's brothers and sisters, what we see is that her brother has some nosebleeds and her sister has easy bruising. We go up more generations, and her parents, Dolores and Dennis, well, Dolores is healthy, but her dad, Dennis, actually has had some childhood nosebleeds and some bleeding after tooth extraction. So we're going through all this to get information on who's affected, What features do they have? And what does that put together for us for a whole picture for the bleeding condition in this family? So what is this telling us? Well, this is telling us that males and females are both affected in this family. And it doesn't appear that males are any more seriously affected than females. And it's also telling us that we see some slightly different features. So we are seeing nosebleeds in a couple of people, but we're also seeing easy bruising or bleeding after surgery or bleeding with menstrual cycles. All right, so this is my check-in where if we were all together, I'd be asking questions and reading the room and seeing how your facial expressions look, but this is a great time to drop some questions into the chat, the Q&A, to make sure that we're getting all of your questions answered. So this is a little genetics 101, and I go over this with the patients that I'm seeing in my bleeding disorders clinics to make sure that we're all on the same page, because for most people, they're not eating and breathing and sleeping genetics like I do on a daily basis. So usually this picture kind of brings back memories of, oh, X's and Y's. And what you'll see here is that typically most people have a total of 46 chromosomes. Those chromosomes come in pairs because we get one of each pair from our mother and one of each pair from our father. And the last pair of chromosomes is unique because they tell our bodies whether we will develop as biologically female or biologically male. So 2 X chromosomes for a female and an X and a Y chromosome for a male. And that becomes important in terms of different inheritance patterns as well. So the chromosomes that are on, the genes that are on chromosome pair number 1 are different from the genes that are in chromosome pair number 2 or 3 or 4 and so forth. But for example, if we look at chromosome pair number 1, we've gotten one of those chromosomes from our mom and one from our dad, which means we're getting a copy of each gene from mom and one from dad. And that's going to also be really important as we talk about inheritance. So I'm going to use some terms here that you may not necessarily, again, use on a daily basis, but that if you talk with someone in genetics or talk with your hematologist, they may actually use these terms. So one of these terms is autosomal dominant inheritance. So what this means is that autosomal means that males and females can be affected. And dominant means that it only requires one gene on one chromosome to have a change to cause the bleeding problems. So even though your other gene that you've gotten from the other parent is working just fine, as long as one gene isn't working, that person will have some bleeding problems. So in this example, we see the mom who's affected here. She has a bleeding disorder, and every time she has kids, she's either going to pass on the gene that works or the gene that doesn't. So there's a 50-50 chance every time she has children of passing on the gene that doesn't work and having a child with the same condition. So with autosomal dominant inheritance, you're going to actually see the bleeding disorder in multiple generations. You may see it in a grandparent and their children, and then the grandchildren, and so forth, with each affected person having a 50% chance of passing on the condition, men and women both being affected. Well, what does this family history tell us? Well, we're seeing Isabella, and she's had some bleeding after childbirth. And what we see now is that her son, Miguel, he had bleeding after circumcision, but her daughter, Sophia, hasn't had bleeding problems. And if we look, Isabella's brother, Martin, has had multiple joint bleeds. And Isabella's cousin, Alejandro, he actually had a brain bleed after a car accident. So what this history is telling us is that females don't appear to be as seriously affected as males, and males appear to be preferentially affected more seriously and more commonly. That's a feature of X-linked inheritance. And that goes back to those X's and Y's that I mentioned a few slides ago that are really important. And the reason for this is women have 2 X chromosomes, and the genes that are on 1 X chromosome are the same as the genes on the other X chromosome. But men have 1 X and 1 Y, and the genes on the X chromosome are not on the Y chromosome. So you can imagine if there's a gene change on their X chromosome, men don't have an extra X chromosome to make up for it. So they typically would have features of the condition. So in this case, with an X-linked inheritance, mom may have one X chromosome with the gene that causes a bleeding disorder, but her other X chromosome may make up for it for the most part. And so maybe she has less severe manifestations or no manifestations at all. But if she passes on that X chromosome to her son, he now is going to have a more serious bleeding disorder. Or she could have a daughter who's a carrier like herself, or her son and daughter who don't get the X chromosome with the gene change at all and are unaffected and aren't carriers either. So with X-linked inheritance, we see that individuals who are related, affected individuals are related through the females, males more significantly infected than females, and females who carry the condition have a 1 in 4 or 25% chance each time they're pregnant of having a son with that condition. All right, one last pedigree here, one last family history. So Aishwarya is coming to us because she's had a long history of bleeding around her umbilical cord at birth, nose bleeds, gum bleeds, mouth bleeds, bruising. But we look at the rest of her family history, and all those A and W's mean alive and well. There's no one else in this family history that's had any bleeding problems that have been reported, and nothing similar to Aishwarya. So this is actually consistent with autosomal recessive. Autosomal, again, meaning males and females affected, but recessive in this case, meaning that mom is a carrier for this condition, dad's a carrier for this condition, and they both pass their non-working gene onto Aishwarya. So she has no working copies of that bleeding disorder gene, and she has manifestations. Her mom and dad each have a working copy, so that's enough to keep them from having any bleeding manifestations, or at least having any severe bleeding manifestations. So with recessive inheritance, there's usually just one individual in a generation who's affected, or maybe that individual has brothers and sisters, but it's just one generation. The parents of the child who has the bleeding disorder often don't have bleeding problems. And those parents, every time they have a child, have a 1 in 4, 25% chance of having another child with a bleeding disorder. So what's considered an ultra rare bleeding disorder? So it depends on what study or what book you're reading, but usually these are going to be disorders that are seen pretty infrequently, and they account for less than 5% of all bleeding disorders. So they're not as common as what you might hear about factor VIII deficiency or hemophilia A, or factor IX deficiency hemophilia B, or von Willebrand disease, for example. These rare bleeding disorders may initially elude diagnosis because they're rare. People aren't thinking about them. They may be more common in certain areas of the world or certain ancestries. And sometimes challenges arise with the diagnosis as the symptom severity. So how much you bleed or how you bleed doesn't always directly associate with the level of factor. So when we think about bleeding disorders, we often think, oh, well, if you've got no factor, you're going to have very severe bleeding manifestations, and you have some factor, you'll have less severe. That's not always such a clear-cut association in terms of the ultra rare bleeding disorders, and that can make it challenging as well. So what we consider in terms of this talk an ultra rare bleeding disorder are going to be the rare factor deficiencies and other inherited bleeding disorders. So our rare factor deficiencies would include factors 1, 2, 5, 7, which I say is the most common of the rare. That sounds kind of like a contradiction. Factor 10 deficiency, factor 11 deficiency, which is actually much more common in individuals who identify as being of Ashkenazi Jewish ancestry or Eastern European ancestry or Iraqi Jewish ancestry. Factor 12, and then factor 13, which is the most rare of the rare. So ones you would see even less frequently than some of the ultra rare bleeding disorders. There's also rare platelet disorders. Platelets are also involved in clotting. And when there's a problem with platelets, you can have prolonged clotting and bleeding issues. So Glanzmann's thrombocythemia, Bernard-Soulier, platelet storage disorders, and sometimes more complex disorders that cause just more than just bleeding. Not to say that bleeding is not significant, but maybe other organ systems may be involved. If your condition wasn't mentioned, that's okay. You're still where you should be. So we still include you in the community, but given our space constraints, we can't talk about everything. But what's important also to keep in mind is, regardless of your diagnosis, the inheritance patterns are the same. So if it's autosomal recessive, whether it's ultra rare bleeding disorder A or ultra rare bleeding disorder B, if I say it's recessive, it's recessive. So you can take this information and apply it to the condition that you have, even if we're not specifically discussing it today. So we went through that whole genetics primer and talked about chromosomes and inheritance patterns. How are the ultra rare bleeding disorders inherited? Well, it depends on the specific type of deficiency or disorder that you have. Genetics loves to have a good exception to the rule, but most rare factor deficiencies are going to generally follow autosomal recessive inheritance. So we're going to really focus on that. This is some basic genetic information for some of the rare factor deficiencies. So it can be like an alternative name that you might see it referred to in different kinds of medical or patient literature. For example, factor 1 deficiency is sometimes called fibrinogen deficiency. Right next to that are the gene names. So some deficiencies just have one gene. Other deficiencies have 2 or more genes, and that can make testing a little bit less straightforward, and the interpretation of the results just a little bit more complicated. And what you'll see is generally many of these are going to follow, again, that autosomal recessive inheritance. How about the rare platelet disorders? So Glanzmann's thrombasthenia has a couple of genes that are associated, Bernard-Soulier. The platelet storage pool disorders are a really interesting group of conditions that we are still learning about. And so far, our understanding of the inheritance and the genes that are involved is really evolving. So that's going to be something that probably will have its own discussion, an own Wednesday webinar further on down the road when we have much greater clarity about that. So what happens if you're sitting here and saying, okay, I've got an ultra rare bleeding disorder and it's one of the ones you listed and it's recessive. What does that mean? If I've been diagnosed with a recessive ultra rare bleeding disorder, in most cases, that means that both of my parents were carriers, which means my mom carried one gene that wasn't working for my particular bleeding disorder, and my dad was carrying the other gene, and they both passed them on to me. So I have no working copies of the gene. My parents may not have had any bleeding issues, or maybe they had some more milder bleeding issues. And my brothers and sisters may also be considered being evaluated by a hematologist, because you can see lots of variability between brothers and sisters and parents. And you can also see different kinds of manifestations that may not always get recognized. So it's worth it to share that information with your brothers and sisters. What if I'm going to have children and I want to know what my chances are of having a child who has the same recessive ultra rare bleeding disorder? Well, in this case, I know that if I have 2 non-working copies of that gene, well, I only have a non-working copy to pass on, right? So at a minimum, all of my children are going to be carriers. They're going to have one of my mutations. But if my partner doesn't have a mutation and doesn't have the condition, then my children aren't going to have the condition. They're not going to have the same condition that I have. So they'll be carriers, but they won't be affected. But what happens if my partner also is a carrier? Well, in that case, then I could actually have children who have the condition. About half of my children would have the condition and about half wouldn't. And these are just general, these are kind of general risks that we give in every single pregnancy. So it doesn't always work out that if you have four children, 2 would have it and 2 won't. We've all been in a situation where we've flipped a coin. You flip a quarter, and if you flipped it 20 times, probably you get 10 heads and 10 tails, but sometimes you would get 12 heads and 8 tails. So math doesn't always work out completely evenly, but this is the general risk that we would give in each pregnancy. What if my child has been diagnosed with an ultra-rare bleeding disorder? In this case, that means that my child inherited one mutation from me and the other mutation from his other parent. I may not have any significant bleeding issues, and maybe his other parent doesn't either. But my partner and I should share this information with relatives so that they know that they may be a carrier and that it would be important for them to be aware of in case they were thinking about having children. And we'd also want to keep it in mind that we would have a 25% chance with more children for our child to have an ultra-rare bleeding disorder. So this is an example of what I was talking about in terms of inheritance. So we're both carriers. We have a 1 in 4 chance of having a child who is affected, a 1 in 4 chance of having a child who doesn't inherit either one of our carrier genes, or we can have children who are carriers. Either they inherited the carrier gene from dad or from me. So again, we just went through a whole ton of information. Don't hesitate to put questions in the chat or the Q&A. We'd love to answer questions as we come up on the end to make sure that we're trying to address everyone's concerns. So what about genetic testing? You know, it's hard to listen to the news or read articles without hearing about genetic testing nowadays. With most ultra-rare bleeding disorders, they can successfully be diagnosed just based on regular coagulation labs alone. If we think you have a factor deficiency, we'll measure your factor levels, and we can often diagnose you from there. There's actually no specific organizational guidelines that require genetic testing for these conditions. So you can't say, what does the American Society of such and such recommend about genetic testing for my bleeding disorder? There really isn't a lot of organizational guidelines about that. So why would we consider genetic testing? Well, we might actually consider it if the coagulation testing that we have done hasn't really clarified or confirmed completely the clinical diagnosis. Maybe those results were a little bit kind of abnormal, not really abnormal. So we really may need more clarification. Some specific mutations may be associated with a higher risk of developing an inhibitor or a higher risk of an brain bleed. Those would be things that your hematologist would want to know to make sure that they were appropriately managing your treatment. It may help us determine what the inheritance pattern is. Again, we love a good exception in genetics. So even though most are recessive, sometimes there can be some different inheritance patterns. So that helps us determine what the recurrence risks are for other family members too. Some families want to know in advance if they're going to have a child who has a bleeding disorder, if they've had a previous child with a bleeding disorder, or if one of them has one. And having genetic testing allows prenatal testing so that a family knows before birth to prepare and plan for the birth of a baby that might have bleeding complications at birth or soon after. It also gives us a better understanding of the different types of clinical features, what we call phenotypes in rare disorders. So again, because they're rare disorders, we don't see them nearly as frequently. So we don't always have as clear understanding of how different bleeding disorders may be in different families. So it really helps us understand, oh, for this factor deficiency, sometimes we see these. We weren't typically thinking about seeing this information in a family. And it's always useful information for other family members, right? By genetics, the nature of it alone, we're not testing in a vacuum chamber. Our genetics is inherited, and we share genetic information with our families. And so having information for ourselves also informs other family members. Well, what kind of genetic testing might be ordered? If my hematologist and my genetic counselor thinks that testing is the way to go from a genetic standpoint, what do we do? Well, it might be that we would just order one gene. You know, if that was the case, then we would just order the testing and it reads the gene and looks for any mutations. If there's more than one gene involved, maybe then we would actually have to test 2 or 3 different genes. And then sometimes if you really are kind of undetermined about the exact diagnosis, we may order a comprehensive panel that may have 20, 30, or 40 or more genes trying to get some clarity about the bleeding disorder that you or your child has to be able to best manage you. Now, what if someone else in my family has actually gone through genetic testing and we know the exact genetic change they have? Then testing becomes very easy for other family members, because all we have to do is test for that very specific mutation and that specific gene. So it becomes much more cost efficient and informative. It's very clearly you either inherited it or you did not. So I have to have blood drawn, right? No one loves to go in and have blood drawn, especially if you have a bleeding disorder, right? You don't want to have to do that. So the good news is many labs accept buccal or a cheek swab. So it actually literally looks like kind of a big Q-tip. And all they do is they send you a kit directly to your home, and you rub your cheek back and forth with a couple of Q-tips, put it back in the package, and mail that package back directly from your home. So that makes things very easy as well. Should I share my history and results with relatives? Absolutely. I know that families, the dynamics can be sometimes challenging. You may not always have the best relations with relatives, or maybe they don't clearly understand some of the things that you're working or dealing with in your history, but more information is always helpful. So giving them information about genetic testing is helpful. That can help them make appropriate health management plans. And it also may help if they have unexpected surgery or a major trauma. Having that information could be life-saving. And it also can help reduce anxiety in the family overall. Is bigger better in genetic testing? You might say, well, you know, we have 20,000 genes. Why can't we just test all 20,000 genes? Well, bigger is not always better. So the more genes that we test, the more likely it is that your provider is going to get variants that we don't know what to do with. These are called variants of uncertain significance. And that means as our genetic testing evolves, the information we get from testing evolves, and sometimes we can test for a lot more things than we can actually explain. So a variant of uncertain significance means we can't clearly say that it causes a bleeding disorder, but we can't clearly say it's benign or harmless, so it falls in that gray area. And variants of uncertain significance can cause frustrations for providers and for patients. So we don't want to do unnecessary testing that may not give us any additional information that really help manage your bleeding condition. The other thing is that the bigger the panel, the more expensive it is, and the less likely it is to be covered by insurance. What you may also hear about, and you'll probably hear more and more in future, is what we call comprehensive testing, which is called whole exome sequencing or whole genome sequencing. So really, for most labs, whole exome sequencing is the most comprehensive testing that you can do right now. And it's looking at all of our genetic information, not just a couple of genes, not just a panel of bleeding disorder genes. It's looking at everything. And I have no doubt this is where the future of genetic testing is going. But in most cases, looking at 20,000 genes is not the answer that we need for them right now. We just need the answer for what's causing their bleeding disorder right now. So we'll eventually probably head in that direction, but we're not there yet. The reason that whole exome sequencing is sometimes used in families when we've exhausted all other options is that we actually do not just testing on the person with the bleeding disorder. We also may be looking at parents and maybe brothers or sisters. And what we're doing is comparing the genetic profiles. For example, for a family history that's informative, maybe we actually see that this little guy here in purple, he has a genetic change that no one else in the family has, and no one else has similar features. So that helps us say, maybe that genetic change actually is the culprit here. But what if we did family testing and it wasn't informative? Well, in this case, we've got the guy in purple who has a condition, but his sister and his mom have the same genetic change and they don't have that condition. So this is a case where it's not as helpful. So Trio testing, so testing 3 or more people, is also really helpful in whole exome sequencing, but again, also has complications in and of itself, as we live in a really dynamic mobile environment. A question that all of us are asking, especially as we're all dealing with, the cost of inflation and so forth, does my insurance cover genetic testing? And it really varies by policy to policy, and it also varies state to state. So Medicaid coverage is different in different states. So not all labs will take state Medicaid, and not all state Medicaids cover genetic testing. Common criteria for whether genetic testing would get improved usually is, how will these results help manage my medical care or my child's? And how can a diagnosis be established by any other less expensive lab test? So sometimes there can't be another lab test that can accurately give that diagnosis, but sometimes not. Sometimes we've already exhausted that. And sometimes the genetic testing really will help us improve medical management. So how do I locate a genetic counselor? Well, so I encourage you to go to a couple different sites. The first site is the CDC website, and that actually lists all of the hemophilia treatment centers in the United States. They're called hemophilia treatment centers, but the vast majority of them work with all bleeding disorders. So it's not just hemophilia A and hemophilia B. They see all kinds of bleeding disorders, including the ultra rare bleeding disorders. So you can go to this website of the CDC and see where the closest HTC hemophilia treatment center may be to you. You can go to our national organization, the National Society of Genetic Counselors. You may not have an HTC or bleeding disorders clinic near you, and any genetic counselor is qualified to take a family history, to discuss inheritance, and to help order genetic testing. So any genetic counselor can do that. It's just that the genetic counselors in the bleeding disorders clinics may just be a little bit more familiar, but absolutely any genetic counselor can help you. Another way of identifying genetic counselors is through the American Board of Genetic Counseling. They're who certify us to make sure that we are all confident and up to date and ready to practice as a genetic counselor. And so those will also enable you to find genetic counselors as well. All right, so as we get here in our last couple of minutes, we're going to do a couple more fun facts about genetics. So be ready to have you answer the poll here. Okay. True or false? About 60% of the human genome has a similar counterpart to bananas. True or false? True or false? Almost all calico cats are female. True or false? The fruit fly has greater than 13,000 genes. And true or false? If a person types 60 words per minute for 8 hours a day, would it take 50 years to type out our genome? So maybe it would take 10, less than 10, more than 10. All right, so our answers are yes. 60% of our human genome has a similar counterpart to bananas. That's an interesting fact. For any of you who are cat people, calico cats are usually female. 1 in 3,000 are male. And the reason for this is it has to do with the X chromosome, and X chromosomes in females get routinely inactivated randomly in cells. So if one X chromosome that puts out orange pigmentation may get inactivated, but the next one it turns off is brown. So you get those fun little beautiful patterns on calico cats, but males don't have 2 X's, so they don't have that X inactivation. True or false, the fruit fly has greater than 13,000 genes? Yes, it does. It's again an example of don't judge a book by its cover. So this little small guy actually has quite a few genes. And actually there's a lot of research that is done on genetics because there's a lot of overlap between fruit fly genomes. So even information like research in terms of like alcoholism in fruit flies. And then finally, yes, if you type 60 words per minute for 8 hours a day, it would take 50 years. So well greater than 10 years to type out your whole genome. So I don't know about you, but that just, makes me tired even just thinking about how long it would take to type all that out. So if you want to, after reading this, listening to this webinar, if you want to share information with your provider, or share information with your family members that they can take to their provider, these are the kinds of questions and information that you should share. So sharing the exact diagnosis, who has the condition in your family, how old were they when they were diagnosed, the child, older, what symptoms did they have when they were diagnosed, and maybe how those symptoms change now, like when they were children versus when they were an adult. And do you know if the person with the diagnosis has ever had genetic testing? Those are all important things to share with family members, or if someone in your family has a bleeding disorder and you want that information, these would be the questions that you would ask them so that when you talk with your provider, you're giving them the complete information they need to go from there and figure out how best to help you. All right. And that is the end of our presentation. So now I am looking forward to answering any questions that may have popped up.
Sorry for my delay. I'm trying to figure out how to unmute myself and share my screen at the same time. So we do have a couple questions for you.
Great.
I'm going to start with just one moment. Actually, I need to gather, some demographics. So one more poll for everyone participating, just to see which one of the following describes you. If you have the time to answer that, that would be great. So my first question for you is, what can families do if genetic testing isn't covered by insurance?
Yeah, and we deal with this frequently. There are some laboratories that have very generous policies that will give you a significant reduction in cash, what it costs out of pocket for you. And usually all that requires is just knowing, how many family members you have that you're supporting in your salary. Sometimes they will give a payment plan that can help you. Sometimes your local hemophilia, your local state chapters may have some money or point you to different grants that are giving money. Your social workers at your HTCs often have access to those resources. And then I also say it never hurts if you're denied 1 year and either your insurance changes or your policy changes. It never hurts to reapproach and have your provider write a letter of appeal, and sometimes just point out, hey, this guideline or this information, we really feel like this is medically necessary. So sometimes it's just giving insurance multiple nudges to try and get some movement, but it's a real frustrating problem.
Yeah. Thank you. What is your biggest takeaway or message that you would like all individuals affected, specifically by rare bleeding disorders, but to walk away with from your talk today?
I think that my message would be that take advantage. You may fall in a category that many people have not heard of your condition, but you're not alone, and take advantage of this global culture to interact with people who share similar experiences with you. But on a personal note, from a genetic counseling standpoint, I'd say that even if you think you know a lot about your condition and have personally educated yourself, so your providers have really done a good job, if you haven't met with a genetic counselor, it's still worth getting that information. Because I would say in most cases, they're still going to give you information that either you hadn't thought of in that way before, or maybe that you just hadn't come across. So it's well worth, even if just one time, meeting with them and sharing information with them.
Great, thank you. What are you excited about that's coming down the pipeline in genetic testing specific to ultra rares?
Yeah, so actually, I was just in clinic yesterday, and we are increasingly considering whole exome sequencing for some of our patients. This was a pediatric clinic. We've already gone through all the standard coagulation labs that we can order. We've already done some very basic genetic testing and really haven't gotten good clarity, and families are really just want a diagnosis. They're tired of that diagnostic odyssey of trying to get clear information so that they can make sure that their child or themselves are getting the best care that they can. So we're starting to think a little bit more broadly about whole exome sequencing. So as the cost of that comprehensive testing goes down, as insurance starts to realize that, you know what, if we had just paid for this testing to begin with, instead of the 10 different tests that we've done already, we probably would have saved money. All those things will combine, and we can start doing that a little bit more routinely so that people don't have to go months and months, or sometimes even a year or two, trying to find an answer.
That's great, thank you. What has been one of the biggest challenges in your genetic counseling journey?
I would say what one of the previous questions is really working with insurance. We see that many times insurance has very clear qualifications about what will and won't be covered. And we work with families, and we realize that there is sometimes just such inequities in terms of what people can access. And when a lab says, well, we'll only charge $250 for this, and you can split it up $125 over 2 months. Well, you know what? For many families, that $250 is the difference between whether they can make rent or feed their family. And so that's really frustrating, that not being able to access testing can impact the ability to really give families some answers. And I don't have a good solution to it. I think that's it. And obviously, genetics isn't the only part of that's influenced by inequities in terms of accessing care, but one certainly that we all should continue to work on.
Yes, absolutely. That's great. And then aside from checking out your local HTC, how can we connect with a genetic counselor?
So I would go to the National Society of Genetic Counselors, nsgc.org, and there is a button that says find a genetic counselor. And you can search in a variety of different ways. You can search by state, you can search by city, you can search by specialty. So hematology is one of the specialties that are on there, or hematology oncology. So some genetic counselors who are primarily working in cancer will still see some of the hematologic issues because of being part of their larger department. So you can check it out there, or you can also go to the American Board of Genetic Counseling, that by law maintains a list of all individuals who are working and have certification for genetic counseling, and you can look there for your state or your city.
Fantastic. So I have a question from Connie on YouTube. Why is testing for these ultra rare bleeding disorders like factor 7 deficiency and factor 5 not screened or tested in newborns, especially if the parents are diagnosed? She continues with a comment of, both my husband and I were not diagnosed until her mid-30s, and at 49 years old for him. We must consider this issue when folks are younger so people do not suffer with symptoms for so long.
And that's a great point. So current newborn screening really is not family history driven in many, so just population newborn screening is geared towards conditions that may need immediate intervention through dietary management or so forth. And none of the bleeding disorders are actually on newborn screening panels. So unfortunately, newborn screening for infants really is family history driven, which doesn't help when there's not always a family history of that. There are some newer carrier screening panels. So for families who are thinking about becoming pregnant, that are beginning to assess some of these rare genes. So factor 8 and factor 9 are on there. I know there's not the ultra rares, but they are on there. But it's an ongoing issue. But I would say that if there is concern about young children, and you have a known family history, that's where a genetic counselor can help you and actually can come up with a plan for testing immediately after birth, kind of like a birth plan, so we don't miss anything.
Fantastic. Thank you. I don't have any other questions for you, so I'll leave it just a moment if anyone wants to throw anything else in the Q&A. But that was a fantastic presentation. Thank you to everyone for participating in the polls. It was different this week. Fun and exciting for me to see everyone's answers as well. Just one more second before we sign off. Alrighty. Well, I'd like to thank you again, Tahnee, for taking the time to join us this afternoon. We appreciate your time and expertise very, very much.
It was my pleasure. Thank you so much for having me.
Of course. I'd like to thank each one of our viewers for joining us as well. Please note that this recorded webinar will be available on Friday, October 14th at hemophilia.org under the Events tab with all of our archived webinars. Also available in the Events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week.